Yeah, we'll start in 2 minutes time. We'll start.
Good evening, sir.
Good evening, man, sir. In hymen fashion case on the Joy day.
Yeah.
Interesting case from Joy. I'll be presenting that. Before that, one short case. Okay, I think we'll start now.
Okay.
So, good evening to all of you. I will share my screen. Is my screen seen?
Yes, sir, it's same.
Okay, so in the last class, I was talking to you about the upbeat nystagmus, the type of nystagmus which you get in upper midbrain, pons, and lower medullary lesion. In the upper midbrain lesion, the nystagmus increases on looking up. Whereas classically, in medullary lesion, the nystagmus increases in amplitude, there is upward movement on looking down, the reverse of what you usually get in an upper midbrain lesion. And that is, last week I could not show the video. I thought I would show the video first. This boy had a cavernoma of the medulla, which is blood, and come with alexia and you're looking up, he has got a bean nystagmus, but looking down, the amplitude grossly increases on looking down. It's a classical appearance of medullary lesion producing a bean. I will show the video once again. Looking up, there is subbean nystagmus, but mild in amplitude. Looking down, it is gross increase in the amplitude or looking down. That is the picture you get in medullary lesion. And this is due to the affection of the intercalatus nucleus of Stardarini, I cannot know how to spelling that, Stardarini and nucleus of roller. This is the nucleus of intercalatus nucleus. The other is a nucleus of roller, which last class I told you is the pathway which inhibits the flocculates. Flocculus, which in turn inhibits the separation secondary canal and the pathway from BTT. Last class I told you about that pathway. So this is the particular nucleus where the lesion of which can produce a upbeat nystagmus. Okay, I'll go to the first short case. This is a story of a 56-year-old man. He noticed difficulty in elevating his arm for the last 2 weeks and difficulty in brushing his teeth of the same duration, primarily compared with the right upper limb. He also gave history of dragging of the right foot for the last 1 week. Total duration is only 2 weeks. Difficulty in elevating the arm and difficulty in using the hand for brushing and dragging on the right foot. There was no sensory complaint, no bladder problem, no root pain, no paresthesia. This is the video of the patient. Painless were all normal. Movements were normal. There is no arm dripped anywhere. Tone appears spastic on the right upper limb. Left is okay. That is slightly spastic. There's also primitive spasticity, you can make it out. And it was mildly weak on the right side compared to the left side. Deltoid power was normal. Biceps also normal. Dexterity was okay with the right hand, not much of a problem, except mild slowness. There is no finger nose incoordination. Lower limb power was normal. The reflexes brisk, normal in the upper limb. Normally elicit in the upper limb. Triceps appears slightly brisk on the right side. Finger pressure was however not elicitable. Abdominal reflexes were intact. Lower limb, both knee ejects were brisk, slightly more brisk on the right compared to the left side. Ankle ejects were normal. Plantar was upgoing on both sides. I don't know to withdraw it or not. It was upgoing. Both sides it was upgoing. Sensations were all normal. Vibration also normal. Joint sense were all normal. Like specifically in the little finger, holding high cervical cord compression, there is not. Thrombus is negative. It's got spasticity of both lower limbs, slightly more prominent, more spasticity on the right side. Left Cori. Cori is spastic, left side. Right side is definitely there is spastic. He could do the tandem walking, but occasional swing to either side. So, an examination, Kalen's normal. Spasticity to the right upper limb and right lower limb. Mild spasticity to the left lower limb. Power all normal except the hand grip weakness. DTR all normal in the upper limbs, probably slightly brisk right triceps on the right side. Finger pressure could not be elicited. Knee jack brisk bilaterally, right more than left. Ankle jacks normal. Abdominal reflex present in all four quadrants. Sense system normal. Gait spastic. Plantar both upgoing. So, what is your localization and what investigation you want?
Cervical myelopathy is the first possibility, sir.
Correct, yeah. Because the 2 weeks history of right upper limb weakness alone is cervical myelopathy. Okay. What nature of myelopathy will you keep in mind? Compressive myelopathy or demyelination, something like that.
Maybe non-compressive, sir. Abdominals are preserved.
Yeah, very good. Yeah, correct. Maybe non-compressive. Okay. Let us see the investigation. But only 2 weeks duration and asymmetrical. Asymmetry of 2 weeks is little odd. Usually non-compressive long duration and asymmetries can occur, but not that common in non-compressive myelopathy. More often compressive myelopathy. Anyway, what investigation you want now?
MRI, sir. Cervical spine.
Okay, this is cervical MRI. Sagittal cut. This is the coronal, axial, tribo downward. One. No lesion could be found out on the cervical cord. Okay, cervical MRI is normal. What else you want?
MRI brain, sir, in view of asymmetries.
Correct. Very good. That's why I also thought MRI brain was done. This is the MRI brain. This is a diffusion sequence. This is the flare. This SWI. No hemorrhagic lesions could be seen. So now MRI brain normal, cervical spine normal. What else you want now? Two weeks history.
Any fasciculations?
No fasciculations could be seen, no cramps.
Brain, is there any hyperintensity flare in posterior limb of internal capsule, sir, bilaterally?
No, that okay. Here, no? Yeah, there is some hyperintensity in the null capsule. Correct. Yeah. I missed that finding. Okay. What is it? Some suggestion of hyperintensity. Here. This is what you meant, no?
Yes, sir.
Okay. So what do you have in mind?
Some pyramidal lesion tractopathy.
Okay, very good. Right. Okay, let us see that. After you have said that there seems to be hyperintensity here also, correct? The first go, I thought it was normal. And since you mentioned, then I know what you said is correct. Okay, so what do you want?
Similar regions are seen in the diffusion also, no, sir? It's normal, sir.
That can be normal. Sometimes this kind of thing can be seen normally seen. So when something is symmetrically seen, always we have got some doubt, no, because that's a problem. But there seems to be some hyperintensity, agree with that. But here also you can see in the medulla, in the midbrain also, posteriorly you can see here. So there seems to be some hyperintensity in the diffusion also. But they are all symmetrical, so how far it is relevant, we don't know. Here also you can feel some hyperintensity. Okay. Now what do you want me to do?
EMG.
Okay. CSF 2 weeks history, no? EMG for what?
To roll out ALS, motor neuron
Yeah.
disease.
But 2 weeks history.
Rarely.
Yeah, correct. Right. Okay. So CSF was done. I did a CSF first. Protein was 27. Sugar no cells.
So CSF for what diagnosis in acute stage, 2 weeks?
No. Any myelopathy where we couldn't find any structural pathology short duration, which is asymmetrical, rule out some inflammatory condition also. Inflammatory and demyelinating pathologies where this MRI may not pick up all the time. I had a patient with MOG myelitis with a normal MRI, but she CSF showed pleocytosis. Subsequently, the antibody came as positive. Positive for MOG. Always consider treatable before thinking of non-treatable conditions. So other things you can, okay, what else will you like to do?
B12, sir.
B12 can be done, but absolutely no post-ocular sensory loss in this patient. There are one hereditary metabolism of homocysteine where you can have pyramidal signs, but that is usually seen in children. In adult, as Mohan said, we have to think of motor neuron disease. So NCS was done. This is NCS is normal. So EMG was done. This is the EMG. Positive sharpness and fibrillations. In between, you can find the fibrillation also. And fasciculations in between. That's a fasciculation. That is on the FDI. Those large amplitude polyphasic potentials with increased recruitment. And incomplete interference. So that's the innovation. I think I skipped that the finding. So read from the right lower limb, tibialis anterior. Again, you can see that positive shaft was coming all along. Large amplitude potentials, polyphasic potentials with increased recruitment ratio. Then did a paraspinal, thoracic paraspinal. Again, fine fasciculations. So it's a case of motor neuron disease or Mann-Server study. Now the problem is that it's very hard to tell the patient that in 2 weeks history, telling that you've got a dreaded condition is going to be a progress, very difficult. So there's such a thing is not uncommon. I have seen acute presentation of motor neuron disease over a period of 1 week. That also I have seen. So this possibility do exist, rapidly progressive motor neuron disease. Such patients do worse. Anyone has got such experience with rapidly progressive motor neuron disease? Okay, any questions in this patient?
So should we exclude secondary cause, sir, like paraneoplastic in view of rapid progression in age?
Yeah, definitely we should have. That is a good thought. We should rule out the possibility. But previously I used to do all workup for paraneoplasty, never found any positive thing. Rarely lymphoma can produce manifest like that. But that is not usually in this particular human element finding is slightly uncommon in a paraneoplastic type.
Usually, bulbar onset ALS will have a little faster progression rather than limb onset.
Yeah, correct. That is correct. That to 2 weeks time, that's very odd.
Yeah, this is limb onset.
Limb onset, and it involved all the 3 segments. It was
Yes,
the
sir.
paraspinal muscle, lower limb, and upper limb.
Yes, sir.
Right.
The hemiplegic variant is described.
Yeah, Mills variant. This is a hemiplegic variant. That's also usually a little long duration. Okay, now got a very interesting case, a Hyman question case. This case is referred to me by Dr. Joy, gets it to him. So he has presented with most of them are videos, short videos. I split into many videos, and then each video contained a particular finding, interesting finding. So that we have to sort it out. Let us see. This man is presented with acute onset of the following problems in a 60-year-old man. Joe never told me the history of this patient, so I don't know. This is the history I thought this my patient might have been having. This is the video of the patient. Okay, look very carefully. It's asking who is sitting on the left side. Made a sister to stand on the right side. Asking who is there. He's telling his wife. Ask him look to the left side. He's still telling wife. He was asked to point out touch his wife. He was asked to touch his wife. Ask the doctor's hand. Was asked to touch the hand of the finger. He's taking the hand somewhere. Okay. If you want to see the video once again, otherwise I'll go to the explanation. You want to see the video? Okay. So what are the abnormalities you have noticed in this patient?
Please show us the video again, sir.
Yeah, definitely. All IMN first you have to review again. I saw this video 3 times. It's not that simple to decipher out the abnormalities. Ask him who is standing on the left side. He's telling his wife. He brought the sister to the right side. Still telling his wife. Ask him to look to the left side. Say again telling wife. Ask to point out the wife. Touch the wife. Pointing somewhere. Then he has to touch the with the finger and nose.
Palinopsia, sir.
Pardon?
Palinopsia.
Not palinopsia.
Optic ataxia.
It is
Cortical
not.
blindness.
Okay. He is not blind.
Visual scanning problems, some optic ataxia related.
It's not optic ataxia. Optic ataxia means that we have incoordination or taking the hand to the target. But I'll explain it in detail in every aspect of this patient. Here, what is happening? Pardon?
Visual agnosia, sir. Visual agnosia.
Not visual agnosia. I'll tell you. Each I'll explain. In optic ataxia, he will be seeing the target exactly in the correct place. He will take the hand exactly to the target, but it produces an ataxia on reaching the target. Just like how do you know finger nose ataxia and cerebral lesion? Just like that only. Only thing is, it reaches the target, but it does not reach the exact point. It will be ataxic. Touch the nose, it will be no problem. Here, he is taking the hand somewhere else. The objective finger is here, he taking the hand to somewhere else only. So that is not optic ataxia. It is not visual agnosia because it's not a problem of recognition. He's asking to point out where it is.
So this is a neglect, sir.
It cannot be neglect because it's not on one side. What is the thing which you exactly notice? His eyes are stuck to one point, correct? He is not looking at either the wife or the new person coming to that, nor at the finger. I'll show the video once again. Now look at that. One more thing, I'll do 2 abnormalities. One, his gaze is stuck to one vacant stuck to a distant object somewhere. But he is not looking at his wife or the new person coming in. 1. So the second point is that when he asks to touch the finger, hand is going somewhere else. As if he is perceiving the hand in another new place, not in the correct place. So these are the 2 abnormalities. Let us see the one video once again. Look at the eyes. He is looking straight somewhere else. Then he's pointing out where wife is there. He's brought the sister, again looking straight only, not looking at the person. He's trying to look, but the eyes are on the face. Ask him to look to the left side. Again, eyes are straight. Again, look at the hands. Eyes are not on the face. Then by chance he saw the wife, but now he's pointing the hand somewhere else, not in the position of his wife. Able to touch his hand is going somewhere else. See, his hand is going somewhere, not in the direction of finger at all. That's not optic ataxia. Okay. Yeah, please.
Visual
Sir, is it oculomotor apraxia?
Yeah, one possibility is an oculomotor apraxia. That's a good thing you have to think. Very good. What else? Correct. This is some kind of an inattention problem, or two things are there in this patient. I'll tell you what is it is correct. This is called visual disorientation. That means I'll explain exactly what disorientation is. In the subsequent slide will tell you. He does not know where the object is placed in the space in front of him. How far it is it to the right side or left side or not? That is visual disorientation. That is defective spatial localization of the object for the patient. Second thing is that eyes are not moving with the targets. If somebody is coming, he's not moving. Normally, what you should look into the person. He is not looking. He's looking straight only, as if he's stuck. So two things can happen. Either it could be oculomotor apraxia, as you said, or something making him fail to disengage from the fixation point. Okay, these are the two possibilities with that. Now let us analyze one by one. He is not looking at the target. He knows somebody is standing nearby and hear her, but could not direct his gaze to the target. It looks as if he is not able to shift his gaze, as if it is stuck. Is it oculomotor apraxia as a possibility? Is it a sticky fixation? Both are possible. The second problem is that he is searching the object somewhere else, not exactly where it is localized. It looks as if he is seeing the target somewhere else. Okay, the finger is pointed out, shown him. He is taking the hand to a different place, somewhere to the right of the hand. That means he is seeing the hand on that area. That is a visual disorientation. Okay, now I'll tell you about what is disorientation. Unable to localize the spatial position and distance of objects despite normal visual acuity. The spatial impairment is restricted to visual modality only. The patients are able to localize auditory stimuli and use proprioceptive input to judge the relative localization of two objects. Patients with visual disorientation are unable to correctly judge the location of the object or appreciate its distance from the body, as well as relative location of the different objects from one another. Not only the distance between you and the object, between the distance between the two objects. So what will happen? Suppose he sees a two chair close by. He may see them apart and may walk into it and hit against the chair. So these patients are functionally blind because that is somebody's cortical blindness. They're functionally blind because they do not look. So they may see the wall straight in front of them. Far away from him. Actually, just in front. So he'll bump into the wall because the spatial localization of the object is at fault. Patients so afflicted may bump into things and be unable to negotiate paths and doorways, even in normal familiar territory, and may walk directly into obstacle even though he sees it clearly. A unilateral parietal lesion produces contralateral visual disorientation even without a homonymous semianopia. So what do the result lead to? Leads to mislocalization in space, misjudge the location distance of the object, misjudge the relative distance between the two objects, unable to find one's way even in familiar surroundings, unable to grasp or point accurately to the object within its range of vision. They may have difficulty with daily activities such as walking around the obstacle in the room, even reading, as this requires the eyes to correctly move from line to line. Pathophysiology, defective integration of the location of the object with the internal egocentric spatial representation of the environment. Your internal representation of the body schema with your localization of the space, object in the space. That is the one which localization of the object in the space. It's bilateral parieto-occipital lesion near the angula gyri is the location of the visual disorientation, or putting in other words, the dorsal stream. In unilateral parietal lesion, you can have a contralateral visual disorientation. So I will show another case of the literature. This is from the continuum. Now you look at the MAVA patient and this patient. Sorry, what happened? This I shown the video before.
Can you see my hand?
Yes.
Grab it
Yes.
for me.
He's searching for the hand.
Where is it? You got it.
God.
Where is it?
You'll find it in a minute. Well done. You got it. Very good. Well done.
So that's exactly what our patient are searching the hand somewhere else. Now coming to the first part of the video, also the video once again, this part only. Look at the eyes. Not looking at the person in front, not to come to the front. You look at the eyes, not looking at the face, looking at some. That look to the left side, still is not lifting his gaze. So what do you find this thing? So is it oculomotor apraxia or sticky fixation? Both are possible. Let us see now. Now this is the second part of the same person video. Now let us see what is happening. As we look to the right side, able to look. Left ear is able to look to the left side, but not able to look up or down. So look down, look up, look to the left side. He is able to shift his gaze to the left and right, but up and down it is not able to move. Okay, that's what you observed here. So what the abnormal notice is able to look to the lateral side and command, but not to look up and down. Could it be a vertical gaze palsy? Possible. We cannot say no. Or is still a sticky fixation. Fixation may not be there all the time. Sometimes he may look, sometimes he may not, the eyes may not be sticky, sometimes may not be sticky. Why that reason I will explain later on. These are the two possibilities in this period. Because previously also you had a sticky fixation. So we can be the sticky fixation also. So like this part of the video. Now let I look left, up, down. Now he's looking at correctly. So is it a oculomotor apraxia now? It is not. So he is able to move the eyes in any direction, up and down. So initially thought the upward movements are restricted, but it is not. At that point of time, his eyes got stuck, not able to move up and down. So what do you think now? No gaze palsy, no oculomotor apraxia. So what is your final impression? He was unable to disengage his eyes from where he is looking and look at his wife standing nearby. He goes on gazing in the front, does not make an attempt to search despite hearing the command. This can be due to loss of saccades, but disproven in the subsequent video, which I have shown subsequently is video ocular motion moment. So what is this problem? It's called spasm of fixation or called sticky fixation. Now, his eyes are, what is the spasm of fixation? Eyes are glued to the initial target which he was looking and unable to disengage. That is spasm fixation. It looks as if his attention is, there is also somebody was also telling this attentional problem is correct. It is as if his attention is restricted to a small area in the visual field called spotlight attention. He is attending to one area, but all other areas is neglecting on that area. So it's a focal form of is one type of a simultanagnosia. That's a dorsal type. Again, I will tell you later on what it is. It's a form of, so spotlight attention or a sticky fixation where the patient is unable to shift gaze from a particular point is because he neglecting the other side. Due to the attentional problem. So it's a form of simultanagnosia. It's a condition in which patients are unable to simultaneously appreciate multiple objects or multiple elements of an object in the same visual image, thereby enabling to appreciate the meaning of the whole. Patients are able to recognize single objects very well, but a difficulty when seeing objects in an array, so-called piecemeal perception. They cannot find objects in a cluttered environment, get lost while reading. They may jump from one line to another and go back to the first line again. When gazing at a pin, a patient may fail to see a candle light located 2 inches away. When shown a picture of a kitchen, he may report seeing only the refrigerator. This already in a cookie picture, you already know. When shown a number of 1089, he may report seeing only 8 because attention is related to that area. There are two types, there are in fact 4 types. So the main 2 types are dorsal type and the ventral type. Dorsal type is due to the lesion in the dorsal stream. The ventral type to the lesion in the ventral stream. The dorsal type is the one which is having in our patient. There is a defective attention, where the attention is restricted to a small area in the visual field. That is failure to see more than one object at a time in an array of multiple objects. Ventral stream disorder causing simultanagnosia due to slowed visual processing speed, failure to simultaneously recognition of the individual part of a multi-part object. This already told thee. So I think I'll skip the various types of simultanagnosia. One is to sticky fixation, which is already told. Can be due to disconnection syndrome, defective eye, saccadic loss also can produce simultanagnosia. And also due to frontal lesion, where the patient is unable to identify the meaning of a thematic picture, because you have to link together all the aspects to have a meaning to the whole picture. That is done with frontal lobe. So in all these sites, you can have simultanagnosia. I think I'll skip this thing. So our patient has got a defective attention in the sense that attention related to a small area in the visual field. So he's only looking at that area. He cannot disengage from that point of attention to a new person, a new target. So lesion the dorsal stream. Okay, any questions in that?
This is similar to some kind of visual grasp. Patient will be looking at the same.
No. Yeah, you already said this. There's a condition called a visual grasp. There, where the patient is unable to disengage from that this thing. That is seen in the prefrontal lesions, not in the occipital lesions.
Yes.
It's just like your grasp. The patient also goes on looking at that thing.
Yes.
It is something similar to that only. But
Yes.
here the problem is only an attention restriction.
Yes.
Sir, is there any right to left disorientation in this patient? Sir?
Yeah, it may appear, what you said is correct. The initial thing, when the wife is shown, he is pointed to the other side. Not because he is unable, when the person is unable to localize where the person is, you cannot assess his right left disorientation. Okay, that is a problem with hypertension. Any one abnormality in one modality may influence the testing of other aspects of the hypermental functions.
Sir, optic ataxia, how to differentiate this, sir?
Yeah, in optic ataxia, I think there's a video which is again Joy's video, which usually show. In optic ataxia, if you take the same patient, ask him to look at the finger, the person will be touching his own nose very perfectly, correctly to the nose. But the patient's finger reaches the target. It will go in the direction of the target, but it will be ataxic when it reaches the terminal portion. Just like your finger nose incoordination, no? Just like it's an ataxia. Okay, but ataxia to a visually seen target is actually what is happening in oculomotor, optic ataxia is that it's a visuomotor disintegration. The visual input, the localization where it is sitting in the space, is reaching there correctly, reaching your brain correctly, but that information cannot guide his motor movement to reach the target. That is optic ataxia. So he can guide to other inputs, for a proprioceptive input, and to the sound also he will point correctly. Suppose some sound is coming from the right side, he may point to that side correctly. The nose he will touch correctly. But a visual target seen, that visual information cannot guide his motor movement towards the target. That is optic ataxia. Am I clear to you?
Yes, sir. Yes, sir. Yes.
I can, next class, I will show the video of optic ataxia.
Okay, sir. Okay.
One more. Is this a visual agnosia, sir?
Yeah. No, it is not a visual agnosia. In visual agnosia, I'll come to that. There are examples of normal visual recognition in this patient itself. In visual agnosia is the failure to recognize the meaning of the object. That is visual agnosia. It is not there in this patient. In visual agnosia, he will be gazing at the object. He will be seeing the object, but cannot recognize what it is. Here he is not gazing at the object.
Oh.
Is it clear to you?
Yes, yes.
Yeah.
So what was
I'll
the
show-
etiology in this case?
No, I'll come to that. Etiology part is all I'll show you.
Okay,
There are
sir.
many more findings in this patient.
Right.
There are for 5 more videos, so same patient.
Okay.
Okay, what does this video show? The next part. Look very carefully. He's touching the nose, touching the finger correctly. Touch his left finger, correctly touched. Though there is no optic ataxia, correct?
Yes.
He's reaching the target correctly, no incoordination.
Yes.
Okay. Now you may ask, say, now he's doing it correctly. Previously, he's asked to touch the finger of the doctor. He was not looking at the finger. Why? Because presently his visual attention is focused to the finger. Previously, the eyes was stuck to some other place. If you want to check the optic ataxia here now, sticky fixation now, he has to move the finger to new place. He will not be able to look at the new place. Eyes will again stuck to the original place. You understood? Okay, suppose you're moving the finger, now you're touching correctly. Suppose you move your finger to a different place and ask him to touch the finger, he will direct his finger to the original, the previous place itself. Will not go to the new place. Okay, because eyes are stuck to the initial visual field. So here the spasm of fixation is to the finger only. It cannot shift it to the new position if the finger is moved. Okay? So he has no optic ataxia. Then why was he not able to direct his hand to the target initially in the first video shown? Has the visual disorientation disappeared? No. That tells you that his main problem is sticky fixation. This shows that at the time of testing the second video, the one which I have shown just now, says are already on the target and therefore could direct his hand towards the target. If you had moved the hand to a new place, the sticky fixation would have become manifest. Okay, clear? Okay. Shall we go to the next? Okay, right. If any doubt, please stop in between and ask. Now let us see another segment of this patient. This will answer your question, previous question. It's asking what it is. It's telling it is pen. What is it used? It's for writing. What is that thing is telling? As asked. He's trying to look at the object various angles. Trying to decipher out from the looking at the various angles. He's able to look at the. He said correctly. Okay. So that means he could recognize even the seal and the pad, which is not a common object which we use, which he uses. So it's even that means he got a good visual gnosis. So recognition object is correct. But it took long time to bring out the answer. Why? Because again of sticky fixation. So that is why one abnormality in hyperpigmentation can influence other tests also. To decipher out what an object is, the three-dimensional object, you have to look at the various aspects of the object. You have to scan each part. Then only bring out the meaning of the whole object. So you scan it, take a long time to understand what the object is. But he has no gnosis problem. He recognizes it correctly. There's normal visual recognition, but he could recognize only after a long time looking at the object from many angles. It also could be due to his visual disorientation, sticky fixation, where he could not make the necessary microseconds to decipher out the various features of the object in the three-dimensional perspective. That means putting in simple terms, he could not scan the entire object. But he has no visual agnosia. Okay?
Okay.
Any question? Yeah. Now go to the next video. He was asked what is the color of the object. He said, he asked what is the color of milk? White, he said. So he is to shown a blue pad, he said correct blue. Then he was asked a question, what's the color of milk? He said white. So what is the meaning of the second part?
The visual memory.
Ah, correct. Very good. That means, so in visual agnosia, the problem in a true visual agnosia, agnosia can be two types. Visual associative agnosia or semantic agnosia. What do we mean by that? A person may not be able to recognize an object for two reasons. The perception is normal. The perception is not reaching the memory bank where the similar object is stored in his brain memory. That connection is lost is the true associative agnosia. Then memory bank also lost its memory of that object. What will you call it? You can't call it an agnosia. Because agnosia means perception should be intact without meaning, but that the memory of the object should have been in his brain. It should be a disconnection syndrome, actually. The memory itself is lost. It's a semantic memory. It's a dementia. It's a restricted form of dementia for that particular object. And that's called semantic agnosia. So conclusion, normal color recognition naming, no semantic agnosia. He could tell the color of the object from his mind. That means that memory of the object is also intact. Why I'm telling like that is that sometimes, if you don't ask that question, a person may say, what is it? He could say, I do not know. What is it used for? Still, I do not know. It can be two things. Whether that object is not in his brain at all, semantic part of semantic dimension, or that is in there, but he cannot, visual information cannot reach that idea. That is associative agnosia. That is not called semantic agnosia. The first one, where the memory bank is lost, is called the semantic agnosia. Okay, is it clear to you now? So semantic agnosia is not agnosia at all. It's a misnomer. To call agnosia, the memory bank should be normal.
Okay.
Okay, let us see this video now. Has to read. He's asking what it is. He could not. It's not the native language. He said it's not clear to him. He could not read even Malayalam letters. He said he could read them earlier. There's one Malayalam letter is shown. He's taking his hand somewhere else. That shows a visual disorientation. Again, he's pointing to the hand. Ultimately made out that point where the letter is written. He could not read that thing. He asked to write his name. He written is very correctly. Nandakumaran Nair. He asked to read what is written. He could not read. They written a Malayalam thing. His name is Malayalam. It was a Malayalam word letter Na, but read it as M. That means he could not read even English letter nor a Malayalam letter. Okay, but he could write write his name completely.
Alexia
So
without
alexia.
Alexia without A.
Perfect, right. So he could not read even single letters, either English and Malayalam. What do you call this thing? This kind of an alexia?
without agraphia, disconnection syndrome.
I know, that's correct. What is it? In the alexia itself, this is called global alexia, in the sense that he cannot even read a letter. There are other alexias, surface alexia and phonological alexia, where the person may be able to read in surface alexia, may be able to letter by letter. This I have shown some time back. Suppose you want to say, read a letter, you will read like letter by, say, climb. C-L-I-M-B, climb. That's the way you read. There is surface alexia. But you cannot read the whole word. can only read by letter. Even the letter itself we cannot read, it's called global alexia. Okay. This alexia with agraphia, there is a excitable in the ventral stream. Global alexia is susceptibility to visual verbal disconnection induced by damage to the white matter pathways, disrupting the transfer of visual information to the left hemisphere pericerebral language areas. Now this I will skip. These are two pathways for reading. I think this, I don't know whether this is not relevant to our patient. There's the two pathways. One is the sublexical phonological pathway, the other is the lexical pathway. This I will skip this. Now what this patient had, alexia without agraphia. This is a condition where a patient cannot read but can write. Naming, repetition, comprehension, fluency are intact. Patient cannot read what he has written. They're able to identify single letters one by one, but unable to read the whole word. That is a severe form of alexia. Severe form, even letters also they cannot read. Majority of the patients can still read by sequentially identifying each letter and reading out aloud. Letter misidentification and visual reading errors are common. Site of lesion is in the visual word form area situated in the left inferior temporal cortex, that's a fusiform cortex, is a neural substrate for the orthographic lexicon. The damage to the visual word form area is a frequent finding. So this is the symbol diagram which you can remember. So this is a language area, that is a visual word form area. To recognize what you have written, read what is written, the visual information on the both occipital cortex should reach this language area. Correct? This is situated in the left hemisphere, dominant hemisphere. The visual information in the left visual area directly can go to the corpus callosum to reach the language area. Correct? So usual situation is that if there is a lesion here, internet is unstable. Okay, suppose you find a lesion here, the infarct here in the left occipital cortex, that normally produces right homonymous immunopathy. So right side visual field is blind. So the visual information has to only come from the left sided visual field. That should go to the right occipital cortex. So what he has seen from the right occipital cortex, that it is the right occipital cortex, should reach the visual word form area on the left side, or the dominant language area on the language decipher area on the dominant hemisphere. That should go to the splenium or the corpus callosum. The cranium is also cut. What will happen? You will have homonymous is there with the letters come the other homonymous field. Again, he cannot read because that is disconnected from the information disconnected from the language area or visual word form area. So in most cases, alexia with the agraphia results from lesion of the left occipital cortex. That is what is shown here. That involves the splenium or the corpus callosum as well. Alexia occurs because the vision cannot be transmitted to the intact language areas. There is no visual processing in the left occipital cortex, and the splenium lesion disconnect the visual areas in the right occipital cortex from the left hemisphere. Here is already there is no vision here, so the only visual information has to reach the opposite side. In rare cases, this can also occur with a single unilateral lesion in the subangular cortex called subangular alexia, where the input, like just the previous pathway here, the lesion is here, in the just below the visual word form area, where the input is reaching from both occipital lobe. Again, can put it the same thing. Maybe on one lesion converted to the dominant hemisphere. That's called subangular alexia. Okay, any questions on that thing? In reading alexia part?
Sir, can you please explain once again that diagram? And there was something called orthographic,
Orthographic lexicon. I'll tell you, I'll explain that thing. I'll come to that. In fact, this is the thing you have to, this pathway. Look at this part. When you read a word, it goes to the visual cortex, then go to the visual association cortex. From there, you have two ways you can read. One, how do you normally read? You don't read letter by letter. You read the whole word, correct? Why you are reading the whole word? Because those words are in your dictionary, or the dictionary is called lexicon. So orthographic lexicon is the written words dictionary in the brain, or you put in simple words, the words in the written form in your brain. And this orthographic lexicon is in this area, the visual word form area. Okay, so when you see this particular word, you read whole. Suppose a letter read climb or orange. That orange word is already there in your lexicon. Okay. On the other hand, if I read a new word like a French word, okay, commando, like that, you cannot read that because here that is not in your dictionary, that is not in your brain, that is not in your lexicon. So that how can you still you can read, but you read letter by letter. Suppose you get a new name as a person. What is your name? Some other name is telling. How can you read? Only by letter you can read. So, for example, say some Arabic name or some other name, you can only say K, P, K, K, like that only you can read. So this visual word form area is your lexicon, where the issue that when you see the letters and words, they can directly access through the visual form area and come out and read fast. So this is possible only in the case of a words which are semantic words or meaningful words which are already in your brain. But non-words or a new word which is not in a dictionary, like a name of a place, you have a new person, you cannot read through the pathway. You have to go another pathway called the phonological pathway, which is the perisylvian cortex. There, how do you read? You can only read by letter by letter. That means you read the letter, you sound it in your brain. That sound you are hearing in the brain. And the sound is conjoined to form a word. For example, if we want to read, say, for example, a kernel, C-O-L-N-O-L. This is how I read with the phonological pathway. C-O-C-O, co, L-O, colo, N-O, colono, L, conola. That's where I read. Actually, it should be read as kernel. So through the phonological pathway, I can only by letter reading. So what will happen if the case of a visual word form area is affected, no dictionary, you can only resort to a phonological reading by letter reading. So that is what is called this here, what is called visual word manipulable surface alexia. The vision resort to the phonological pathway. Understood? Suppose this is the perisylvian area is affected, this pathway is preserved. They can read only familiar words, unfamiliar words you cannot read. New place, the place of a new place, you cannot read through the visual form area. For that you need phonological pathway. So these are the two pathways. So your internal orthographic lexicon is this area, the visual word form area. Okay, is it clear to you? I'll mention this one, that brain uses different mechanism for processing unfamiliar words as opposed to familiar words. Unfamiliar words are processed based on the individual letters and phonology of the individual syllables. This is called sublexical system or phonological pathway. Familiar words, on the other hand, are quickly processed based on the recognition of the whole word and their associated semantic meaning. This is more common for words that have specific meanings such as dog, cat, bridge, etc. They have easy imaginability, the ability to picture the meaning in one's own mind. This processing is called the lexical system. These two, this is the two systems which I mentioned earlier. Depending upon which system is affected, you can have surface alexia, you can have a phonological alexia, or a deep alexia where both are affected. So any questions?
Clear.
Okay, now I'll go to the next video. Is this what Joy has written?
നമ്പർ വായിക്കാൻ പറ്റുന്നുണ്ടോ?
Can 8 small 8s in a join together in a 7 version?
7 അത് 8
He's giving the clue. Is it 1, 2, 3 like that? He's not able to mention anything. So I'll show the video once again.
ഞാൻ എന്താ എഴുതിയിരിക്കുന്നത്? ആ നമ്പർ വായിക്കാൻ പറ്റുന്നുണ്ടോ? അത് 2 ആണോ? 3 ആണോ? 7 ആണോ? അത് 8 ആണോ? പറയാൻ പറ്റുന്നില്ല അല്ലേ?
Okay, suppose if you are shown this picture, what will you read? You will read 2 things, no? 7 and 8. Correct? Many 8s are forming a 7. So what is this test used for? This is a test for what?
Dorsal simultanagnosia.
Very good. It's a dorsal simultanagnosia. Now this patient is not able to read that thing. So what is your impression? Is it simultanagnosia?
No, sir.
No, correct. So it's the same. No. Why? Because to dorsal simultanagnosia means he is should be able to see in the 8 here. Only thing is he will not be able to do the 7 formed by the 8s. Okay, understood. So here he is not able to. He is not able to even read 8 or even the 7. That means he has got a global alexia is there. He cannot read the letter or not read the digit. Number he could not read. Such a patient, how can you say about simultanagnosia? You understood? Simultanagnosia is where this patient is telling 8 only, but not the 7 formed by the 8, then only equals simultanagnosia. Simultanagnosia should be able to read small letter or the digit. For example, here he could not read even the small digit 8, which forms a 7. Clear to you? Okay?
Yes, sir.
Yes, sir.
Okay. So again, it is an alexia, part of global alexia. Let us this one. Joy is asking that question.
നമ്മുടെ മുഖ്യമന്ത്രിയുടെ പേരെന്താ?
Name of the chief minister.
ഓക്കെ, നമ്മുടെ സംസ്ഥാനത്തിന്റെ പേരെന്താ?
What is the state where you are living in?
നമ്മുടെ പ്രധാനമന്ത്രിയുടെ പേരെന്താ?
The prime minister.
മോഡിയാണോ, ഇന്ദിരാഗാന്ധിയാണോ, രാജീവ് ഗാന്ധിയാണോ?
Modi, Indira Gandhi, or Rajiv Gandhi. He could not really anything. So what is his problem? It's straightforward, simple problem, no?
Semantic memory loss.
Right, very good. This is semantic, clear semantic memory loss. So, loss of semantic memory. Where is the site of lesion for that?
Anterior temporal loss.
Lateral
Right. Anterior temporal region, inferior anterior temporal region, correct. Bilaterally, you're right. Anterior inferior temporal lobe. So semantic memory is actually memory of facts, principles, and rules. It's actually evolved from episodic memory. Only item of information that is the key points and the factual knowledge without details of the episode as to when and where it has occurred is stored. That's semantic memory. So all what you have learned, your name of the object, name of the persons, your date of your Independence Day, everything is semantic memory. Your vocabulary, all of semantic memory. This you learned at some time in your life, but that means you occurred through episodic memory. But in time, what will happen? That time context is lost. And what remains is that the factual data that forms a semantic memory. So all semantic memory is actually learned through episodic. Okay. So it's lateral temporal dysfunction is an anatomical separate semantic dementia. And unilateral damage does not usually raise the semantic memory. The anterior and inferior temporal lobe appear to be act as essential nodes of or hubs in a complex network involving various parts of the brain, each perhaps storing different types of information. Suppose you have got a, remember a rose, a flower rose. There are many things. It's got a color, it has got a smell or a fragrance you can remember. You must have seen in a garden, the place, or it must have given to you by your girlfriend. So all these things are there in that rose. Okay. So all these factual information of that particular rose, the memory aspect of it is stored in different aspects of the cortices. What the inferior anterior temporal lobe does is that it collects information from all this area to bring out your the semantic aspect of that object. So when you see a rose, immediately all the things will come into your brain. Even your girlfriend also will come into your brain. So the visual information may be stored in visual cortices. The sensory information like texture may be in the parietal lobes. Information how it is used may be held in the frontal. If you see a cycle, you know how the cycle is going. Information on how it moves may be stored in the visual motion area of the temporal lobe. Semantic memory retrieval depends upon the triggering mechanisms that originate in the prefrontal and anterior temporal regions. However, limbic structures are also involved in the retrieval of more recent memories. For recent memory, this in addition to the anterior temporal lobe, it also requires a recent limbic areas, the Papa circuit. Okay, any questions on that memory? Okay.
So episodic memory is in the medial temporal lobe, sir?
Yeah, episodic memory is the Papa circuit in the medial temporal lobe. Medial temporal lobe. Pardon?
No, sir. Semantic memory specifically in anterior and inferior temporal lobe or lateral?
In fact, it's in the lateral temporal lobe itself. The main part is the anterior inferior part of the lateral temporal lobe. It is not in the medial temporal lobe. Medial temporal lobe is the part of the hippocampus and that area, no? The Papa circuit area, medial temporal lobe. This is the lateral temporal lobe, the anterior inferior part.
Oh.
When you say just temporal lobe, it may mean either medial or lateral. That's why I said lateral temporal lobe.
Okay.
The episodic memory called episodic memory, there are three attributes to that. It should be autobiographical. The event should have happened in your life. Whatever you have incurred, only episodic memory. And it's time tagged. Should be have a time context, which is must happen yesterday, 2 days back, 3 days back. And it is contextual. It is associated with some context. You must have seen a girlfriend in particular garden or particular hotel. So that context. So three things. These are the things which are stored in the part of the episodic memory. So it's autobiographical, time tagged, and contextual. These are absent in semantic memory. Semantic memory, only the factual data is there. Ruled, that is there.
So frontal lobe.
Okay. Pardon, frontal lobe?
Any role in this memory?
Memory. Oh, frontal lobe has a tremendous role in memory. It has got many things. One, its main role is the retrieval of memory from the old memory and the recent memory. For that, it also requires the help of the medial temporal lobe. Another important role of frontal lobe is that in consolidation of the memory. See, suppose you have got many things in your working memory. Suppose you are, I am talking to you now, okay, when you're taking class. See, all things will not go into storage. You'll remember only what is required for you, correct? Only those required for examination or something like that. So it is the frontal lobe which sieve out the novelty of the stimuli, which is more important and which is not important. That guides the temporal lobe. See, it will instruct the gate, oh, this is the one you need storing. You store that thing. That is by the frontal lobe. It acts as a bandmaster orchestrator which guides the temporal lobe. Second thing is that it also got sequencing, the order in which it should be placed. That also is a problem with the frontal lobe. It helps to recall in a frontal lobe lesions, but you can recall with cues, but without cues, you can't recall. So it's got a lot of functions there in frontal lobe. the order problem in role in retrieval, role in consolidation, role in the sequencing, role in the arrangement of the events in the past.
So which part of frontal lobe?
It is the dorsolateral part of the frontal lobe. And that too on the left side.
Sir, what about the role of basal ganglia?
In
that is in procedural memory.
Yeah, procedural memory is entirely different thing. That has got there are many aspects in that. That is by the mainly supplementary motor area, basal ganglia, and cerebellum. Then because when you initially requires the reading not require supplementary motor area, in time what will happen, your acts become automatic. Because you can brush your teeth even without any intention on it. It becomes automatic. You can cycle, you are cycling by talking to someone. So that become an automatic act. So it forms a circuitry between the cerebellum, basal ganglia, and the supplementary motor area. That forms a procedural. That is, in all dementias, procedural memory will not be lost. Or that is the last to do. Okay. Shall I show this video?
നന്ദനന്റെ ഇടത്തെ കൈ പൊക്കി കാണിക്കൂ. ഇടത്തെ കൈ കൊണ്ട് ഇടത്തെ ചെവി തൊടൂ, വലത്തെ കൈ കൊണ്ട്. ഞാൻ ഇന്നാണ് തൃശ്ശൂർ വന്നത്, അങ്ങനെ പറയൂ. ഞാൻ ഇന്നാണ് തൃശ്ശൂർ വന്നത്.
He's got a good comprehension. He's given complex combination did it correctly, and he could repeat what the doctor was saying. Normal verbal combination, normal repetition. So where is the final? So these are the videos of this patient. So what are the final conclusion this patient you have? Where is a lesion here? It's got a bilateral lesion. Second, it is got a lesion of the dorsal stream as well as a ventral stream. Dorsal stream, as already told you, the visual inattention, the sticky fixation. The ventral stream has got alexia. And dorsal stream again, dorsal disorientation, visual disorientation is also part of dorsal stream. Okay, and anti-inferior temporal lobe because of his semantic memory loss. Lesions be bilateral, occipito-temporal lesion, bilateral occipito-parietal lesion. Because dorsal stream also is affected. So what could be the problem in this patient? Etiology, acute presentation.
Vascular.
Stroke.
Vascular, yeah, stroke. Maybe the top of the basilar artery or multiple embolism. These are the site of lesion. So this is the MRI sent by Dr. Joy. You can see both occipital lobes are affected. Occipito-temporal region, inferior temporal region. Main affection was on the left side. That is why it's got alexia is very prominent here in this patient. Here. Probably there's one problem. He's got infarct in the left frontal lobe also, and left parietal also, not coming under the tertiary vertebrovascular system. Probably it may indicate an embolic origin also. This is the flare sequence. Okay. Okay, any questions? That's all the story.
So what is the prognosis for the patient?
Prognosis is but since bilaterally affected, the chance of recovery is very, very poor.
He's much better on follow-up. The sticky vision has improved. And
Okay. Joy is taking. It's improved, actually. Okay. But seeing the degree of infarct, no, we don't expect to be that much. Yeah.
He was actually a cardiac patient. He had stopped taking his medicines and only came with this.
Okay.
So initially
He
he
was
wasn't. I never
Okay.
thought that when he came for follow-up, he's much better.
Yeah, probably his age was young. He was in embolic stroke? Joy?
Most likely, sir. Most likely.
Okay. He's a cardiac patient, you were telling, no?
I had a cardiac patient who had stopped all medicines for a few weeks.
Okay. Right. Joy, anything you want to contribute?
No, sir. No, sir. No.
Okay. Thank you. So I think, shall we stop here? It's a long case.
Yes, sir.
Okay. So, right. So if you want someone interested in high mental functions, no, I'm taking class for a certain group of students on every Wednesday. It is already 5-6 sessions are over. Next session is on visual agnosia and dorsal and mental stream disorders. If you're interested, I can send the link to you.
Please.
This is not that in the YouTube or anything. There's only a small group of students I have been taking for the last, say, 2 months.
Okay, sir. Please, sir.
Yeah, Wednesday.
Yes, sir.
That's only on high mental functions, nothing else. Only in high mental functions.
Okay.
Many classes are already over. The attention, language are over. Memory is over. What is remaining is the dorsal, mental and dorsal stream disorders, disconnected syndrome and apraxia. They are remaining.
Okay, sir.
Please send us the link, sir.
Please.
Okay, thank you. Okay.
Sir, how to get the link?
A link, okay. Do one thing. This is organized by the Indus people. They can send the link to you, or I can also send the link. Which address shall I send?
Sir,
You can put it in the CAN group, sir.
Okay, CAN group I will put. Okay.
And
sir, we are not in CAN group.
Okay, put in the CAN group. Okay. So in
We
fact,
are members of CAN. Like I'm from Tamil Nadu.
Okay. Then you can. I'll put in the CAN. That's tomorrow. It's next class is tomorrow.
What is the
8
time
o'clock.
now? What is the time, sir?
8 to 9.
Okay, sir.
8 p.m. to 9 p.m.
Okay.
Okay.
Okay, sir.
Thank you, sir.
Thank you.
Thank you, sir. Good
Thank
night.
you, sir. Thank you, sir.
Night, sir.
Good night.
Thank you.
Thank you very much, sir.
Thank you, sir.
Thank you so much, sir.
Good night. Good night, sir.
Thank you. Good night. Thank you all. Good night. Thank you.
Thank you, sir. Thank you.
Thank you, Bindu. Thank you.